So welcome to this month's episode of the Frontline to Finish Line podcast. We're currently recording this from the BASM Conference 2025, and we're extremely lucky to have with us today Dr. Hamish Reid. So Hamish is a sport and exercise medicine consultant working in New Zealand at Christchurch, and we'll hear a bit more about that in a minute. He's also the Joint Clinical Director at Moving Medicine, and he's been that since its inception in 2018. He's led on a lot of development of their resources, and he was the first author of the Benefits Outweigh the Risk consensus statement that was put out by the faculty. Hamish also leads the Active Conversations course and is a member of the Motivational Interviewing Network of Trainers. So I will go through a bit more of Hamish's career in a second. I'd just like to introduce Hamish. Thanks for coming onto the podcast. So Hamish, if you just start by talking us through your career to this point, how you've ended up in the physical activity sphere like you are, and your current jobs.
Yeah, well, thanks very much for having me for starters. I guess one of the reasons that I was interested in doing sport and exercise medicine was because I felt going through my medical training, I worked in different areas. I was a critical care trainee for a bit of general practice, different things. I felt that we really needed to do better on preventative medicine, and that was something that sport and exercise medicine kind of offered as part of the career pathway, I suppose. So that was one of the big reasons that I went into sport and exercise medicine. When I got my training number, I was kind of fortunate to get an academic training number in Oxford, and what that enabled me to do was to spend some time in the Department of Population Health and working around kind of non-communicable disease and physical activity agenda, and work with Professor Charlie Foster, who was a great influence at that point, and helped me kind of get into the epidemiology and building into some guideline stuff and CMO recommendations and things like that. So I guess that was the kind of avenue into physical activity for me. And then as I was training and started developing some resources for clinicians and things like that, and then that's when the faculty got tasked with some components of the Moving Health Professionals agenda, and run by Public Health England at the time. And that was where, as one of Natasha Jones's trainees, I ended up joining forces with her, and that's where we kind of, the inception for Moving Medicine came from. Yeah.
Brilliant. And now you're in New Zealand, if I'm not mistaken. You're over here very kindly coming to the BASM conference and doing this today as well. What are your jobs out there, and do you have any interests outside of medicine that you take part in?
Yes, so in Christchurch I have a couple of different roles. I work just in a regular private sports medicine clinic, clinical sports, with some wonderful colleagues, and I also am the team doctor for Crusaders Rugby, which is a brilliant sport role. It's an amazing organisation and culture to be working in, and there's brilliant alignment to sort of principles of kind of MI and good really looking after people, I suppose. And so I really enjoy working there for that point, for that reason, which isn't true for all sporting environments. So I feel very fortunate to be there. And as well as that, I have a medical director role for an umbrella company called Evolution Healthcare. That's a private healthcare company in New Zealand, and so help with training, guidelines, development, and some clinical oversight and practice for them. Yeah, so that makes of things, and still kind of have a hand in moving medicine activities.
Brilliant. So, Hamish, the reason we got you on today is to talk about physical activity in people with long-term health conditions, and this is an area that obviously you're an expert in. You're one of the leaders in this field. So we're really lucky to have you for this episode today. For people who are at the BASM conference, we had a stream yesterday that was focusing around this, and it was very well attended, and I think it's a sphere that anyone in SEM needs to be upskilled on, learn about, and educate their fellow health professionals on as well. So to sort of open things up, would you mind just talking us through sort of past landscapes around things like pre-participation screenings for patients with long-term health conditions?
Yeah, sure. And I guess I've had the pleasure of talking about our work in the risk consensus at the moment. I think I'd also just start by saying I wouldn't consider myself an expert in this sort of thing by any stretch of the imagination. I think if I contribute in any way, it's by trying to publish and make available, through Moving Medicine and other things, what experts have truly produced, I think, and a lot of it comes down to common sense in a way. So when we developed moving medicine resources and try to understand what was important about physical activity for consultations, so what healthcare professionals wanted to know and how to implement conversations, there was a range of barriers that would come up time and time again, particularly in our patient-facing work. So all of our disease groups and stuff have patient input in groups, and there's this kind of pervasive fear of adverse events that goes through the patient population. So that when we got to sort of the first iteration of producing moving medicine resources and prescribing movement and the active hospital stuff, actually we hadn't really made any progress in helping address risk and particularly the fear of adverse events. And that was something that healthcare professionals felt very uncertain about how to give advice and what advice to give people about physical activity. And there was this kind of stigma associated with it. So if you are someone that's been diagnosed with a long-term condition, often the way that people view you and what you can and should be doing changes pretty fundamentally sometimes. And so there's this wider whole kind of system issue around the perception of risk that people living with long-term conditions. And our gut feeling was that actually it must be good for these people to be moving more, and particularly if you look at people that are moving, walking less than 30 minutes per week, that's very little physical activity. And we know that those are really the people that, if we can connect to them and help them move a little bit more, it has a massive benefit to their health. And healthcare has a particular access to that patient group, that group of the population, because they traditionally are very difficult to engage in physical activity initiatives. So getting into the risk agenda, if you like, and trying to understand that became kind of pivotal to what we thought was sensible progress moving forwards.
And in terms of managing that risk, what has previously been available to healthcare professionals in terms of screening or stratifying that risk?
That's a great question, because actually there's probably very little that's ever been produced for healthcare professionals about that. And if you talk, so in the recent work that we've been doing, looking at how we frame this for members of the public, we've heard from the healthcare professionals, and particularly from primary care, that actually this isn't something that anyone's trained in, right? So when they're asked to do something like give a pre-participation clearance, we know that at least half of GPs don't want to support that, because they don't feel that they have the skills or the knowledge to adequately do that, and there's concerns around kind of the litigation that's implied to them for that. And the reality is that if someone's going to go and do an activity somewhere, if you don't know what that is, you don't know who the people are that's going to be giving it, you don't know what the circumstances around it are going to be, actually, I would feel that I don't have the skills to give sensible advice about that, So I think there's just a massive hole, really, and there's just been this expectation left to general practice and primary care providers to kind of fill that void. That when we look at the resources that are available, actually they're focused on the kind of sport and leisure industry, and that's where pre-participation screening tools really are focused. And there's been a lot of work put into them over the years, but I guess the problem that we find is there's a pretty high, like maybe between 1 in 5 and 1 in 3 people probably that fill in one of those forms then need to go and see a healthcare professional. And if we have a system, and it does vary a little bit around the world, but in the UK there simply isn't the capability or the capacity of the NHS to support that, and it's mirrored around the world as well. In that circumstance, we see a really big problem with the tools that exist, and particularly in answer to your question, there's not really anything to help healthcare professionals that I've seen that's kind of been produced already.
I think one of the things that really stuck in my mind when we were speaking about this in the stream yesterday was the terminology of the revolving door of the patient going in to see their GP about physical activity. Being told to do more physical activity, going to a gym, being told to go and see their doctor, and to me it just seems like such a barrier. And I think that's one of the pitfalls that we're hitting at the moment with getting people more active, and I guess we'll talk in a minute about how we're addressing that. So one thing that we'll often get asked about by healthcare professionals is about the PARQ screening tool. That's one thing that often people will use. Do you have any bit of information about when that was developed and the sort of the sensitivity, specificity, and essentially whether that is something that we should be using going forward?
So we did a review of the literature around pre-participation screening to try and understand what was out there in the landscape, what tools exist, and then what evidence do we have around, one, their efficacy, their validity, and also their utility, really. And the overwhelming kind of tool that's been studied and developed and published is around PARQ and the subsequent iterations of it. And that's a tool that originated in Canada back in the kind of 70s and 80s. And it's become, if you like, the kind of the sort of global standard really for pre-participation screening. And when the data that is published around its validity, looking at sensitivity and specificity, so how good is that test at identifying people at risk, and also how good is that test for identifying people that are not at risk, right? And the numbers vary wildly by population and by study, and they kind of vary from as much as kind of 5% through to sort of 90% in both domains, depending on what you're looking at. But certainly, if you look in the older populations, then actually it seems to be kind of less useful in those populations. And actually, those are the populations that have the high morbidity, and it's probably because it's at this really high kind of false positive reporting rate. And so it's problematic, because if that's a tool that we have, then it isn't brilliantly identifying and discriminating the people that we want. And when we look at that in real life, so we've got a brilliant partnership together with Nuffield Health, and they've looked at data across all of their gyms. They have data about adverse events, and over the 2021-22 kind of time, they looked at all of their adverse events, and across, I think they have maybe 138 venues, something like that, and they reported 24 adverse events. And they're a well-organised organisation that have implemented PARQ over a number of years, and they found that only 10 of them had PARQs done, and of the PARQs that were done, only one of them had anything that I mentioned on it, which was high blood pressure, and there was no medical record to go with that. So that just shows how difficult this is to implement in kind of real-life situations, and one of the forms that they've done had been done like 20 years ago, so that's another issue with them, is like, how do you keep updating them as well? So if we put that in the context of the situation that you described, like that revolving door, where someone goes to healthcare and then they go to a leisure centre, and then they go back for a PARQ, but they can't go there, so they go somewhere else, they have to pay for it, and you just can't move forward in that system. It doesn't really make sense to put them together, because you can't implement what isn't a particularly good tool. So the real life application of it is just such a massive barrier. Yeah. And also, it doesn't mean very much, right? Because if you go through that revolving door, you just, like, next time you're going to tick, I'm fine, right? So do you have any of these complaints? No, and that's what people do. So actually, when you looked at the cohort in Nuffield and talked to them, actually, yeah, they did have pre-existing conditions, and Davina, who is medical director, has done some great study looking at. I think they've had 1.4% reported of medical conditions on the forms, but then actually, when she went direct to their population, they had nearly 40% of people that were living with medical conditions. So it's not really fit for purpose in terms of helping achieve our objectives, is our conclusion.
Yeah, and I think with those issues in line within the sensitivity and specificity, essentially you're at risk of not catching the high-risk patients because of self-reporting, and you're at risk of sending patients who are maybe lower risk back through that revolving door. And that's one of the issues I think that comes up often, isn't it, with the PARQ, and one of the reasons that it may be something that people are trying to move more away from, to maybe a more pragmatic approach, to that pre-participation screen.
I guess in the UK we see the health commitment statement, which is a big move, in that direction.
So moving on slightly, so concern about adverse events is a big barrier for healthcare professionals talking to patients about physical activity and then recommending physical activity. Now, we touched briefly on education as a reason for that before, but what are the kind of reasons around that concern around adverse events, and what kind of things do you think we can be doing to address that?
From an educational point of view, we have to look at our system really, and we have to look at the kind of continuity of messaging that individuals are getting across the system. I guess we work in healthcare, so we think about healthcare and actually having an approach where healthcare is set up to deal with medical issues, and so what it isn't good at and trained in is forecasting medical issues really. And so if we can have a system that takes that responsibility off healthcare and uses healthcare to respond to medical concerns, then that system is going to work really well, right? And if healthcare professionals can be confident that the benefits outweigh the risks for people to participate in regular physical activity, then that's going to really help with the messaging in terms of then going on to other sectors. Then there is a big kind of fear of litigation as well as a fear of adverse events that are around this. And I think one of the things that may have emerged over the course of time is because we have this kind of barrier to say, well, actually, because you have a medical condition, it's pretty risky for you to come in. If you're going to come in a gym, we have to be really sure that it's not our responsibility when you drop down dead. That's quite a big change for someone that the day before they had their diagnosis would have just walked in there and had been happy with it. So it builds this kind of perception of risk around it as well. So with that, there's a pretty ingrained fear of adverse events within the physical activity sector, and actually a pretty sustained and coherent education process to help us understand, actually what the landscape looks like and what we're trying to answer with any sort of pre-participation contact is really important. And rather than a form that is just kind of ignored, filled in, or that sort of opportunity of a pause before you go into an active environment, particularly if you're inactive, actually is really important as an education opportunity for the individual. So actually that's where developing some resources for the members of the public to understand and be able to essentially go through a process of informed consent to decide what their own risk is, I think is really, really key to that. And that's where everybody at the different stages of their journey should be able to understand kind of their role in answering questions, understand where they can find out more, and then also understand, actually, this is a medical problem, this is outside my scope of practice, it should go to a medical environment. So I think there's kind of different ways of looking at that education, but I guess that's one of the things that we're trying to be really clear about at the moment.
Do you think we're passing our fear on to patients in a way with all the conversations around risk, and do you think in a way that healthcare professionals could be contributing to barriers around physical activity?
I guess from the consultation work we've done over the two risk work we've done, I don't. The majority of healthcare professionals are advocate people doing physical activity, right? So I don't think that there's any fear mongering going on or anything like that. But I do think that our systems promote fear. Like having these barriers to walking, for instance, that's if people are worried about you walking, like you're going to join a walking group and no one's sure if it's safe for you, like that's a pretty big promoter of fear, and for those around you. And it might be reflected that actually one of the biggest drivers for people living with long-term conditions, the biggest enablers for them, is to see people like them with their conditions engaging in physical activity. That's probably the biggest thing that gives them confidence. And it makes sense that, actually if we're stopping them being engaged in anything and putting all these barriers to participation up, that it's kind of the opposite of that, isn't it? So, yeah.
So I guess in sort of thinking about those risks and addressing risks, the faculty consensus statement was developed by yourself and others a couple of years ago now. And for anyone who hasn't seen this, I would say it's probably a seminal document to look at if you are working in the physical activity sphere, or if you're an SEM registrar, consultant, or a GP with an interest in physical activity. So we'll obviously link that. I'd just be interested to hear a bit about how you went about developing that, the key take-home points that obviously are outlined in that, and how we apply that.
Yes, I guess we've used kind of mixed methods, like translational research approaches to try and answer these problems, and so we started the risk work looking, with a big review of evidence, essentially, and sort of partners, Paul Kelly and colleagues in the University of Edinburgh, and so, and equally now we've come into looking at what that looks like for the public. We've kind of reviewed that literature as well, and also looked at the literature around pre-participation screening as it is. So there's a broad range of kind of background evidence reviews that we've put into work, and then there's been a combination. So I think the strength of the work that we've managed to do is it's been very collaborative in terms of coming to our conclusions, and so we've relied on the opinions of experts, we've relied on the patient voice, so we've had lots of patient and public engagement, and we've had lots of engagement with different stakeholders within healthcare and also the industry as well. So evolving statements through Delphi process is really kind of where we've moved on from understanding what the evidence base is, summarising this, presenting it to an evidence group, an expert group, kind of getting a feel for where we might be landing, and then going through a Delphi process to understand and refine our statements. Is kind of how the sort of broad outline, I suppose, of how we've approached these bits of work. Yeah.
So one of the key outcomes from the FSEM consensus statement was that the benefits of physical activity outweigh the risks for people with long-term health conditions. Just interested to know what sort of data that you had that gave you the confidence to give that as the consensus statement.
Well, I guess we have a background of data that very, very strongly says that regular physical activity in the day-to-day lives of people with long-term medical conditions is massively beneficial for their health. Beneficial generally for their conditions, beneficial for preventing other conditions, beneficial for their mental health and general well-being, for social engagement, ability to work, maintain functional thresholds, like heaps of stuff. And so we can. That's a massive thing, right? So then if you look at the risk of adverse events, actually they're reported to be very, very low. And we're not saying that bad things don't sometimes happen, right? And then a really important part of the message is that we can mitigate, the likelihood of bad things happening pretty well with some very simple bits of advice. And if you have someone who is inactive living with a long-term medical condition, and we project through their life course, the impact of them remaining inactive is massive on all of their health markers, all of their health domains, their life expectancy, everything, right? And so that's in essence where that message was very clear to everybody. It was kind of a unanimous opinion, really, amongst everybody that we took what we'd found in the evidence to go and explore. So that was pretty clear to us that that's the case. And I guess just while we're here, I'll just say what the important things to know are. So if say you've got someone who's inactive and is going to start a new activity, the important things for them to know are that they should start at the level they're at currently. So not what they used to do when they did activity, but kind of maybe the amount of activity they've been doing over the last month, and have that as their starting point. And then just build up slowly from there, gradually increment it. And when starting, a really important thing is to avoid unaccustomed vigorous activity. So unaccustomed vigorous activity is probably the biggest risk factor that we kind of know for instance, having a cardiac event or something like that, which is ultimately the things that we're most worried about, or we know that most of the adverse events are actually sort of MSK events. So those I think are just the really, really simple key messages for us all to be confident about. And then the other thing to go with it is that if people are developing unstable or dramatic symptoms of their condition or a different condition like shortness of breath or pain or something that isn't settling, they need to stop their activity and seek like medical advice. So that's where we can use medicine as it's designed to use, and like I said earlier, kind of have them in working. If someone's got an active medical problem, they should not be, being physically active. They should go and get that assessed. But if they've got a condition where they've got stable symptoms, then that's fine.
Brilliant. No, I absolutely agree with that completely. It's a brilliant statement, and like I said, we'll link that in the bio. So off the back of that, what work is being done off the back of the consensus statement, and sort of what lies ahead in that sphere?
Well, I guess it's kind of an exciting time really for this, and it's exciting because of the partnerships that are coming in and around this piece of work. So there's a roadmap being developed with the faculty, Sport England, active partnerships, and key stakeholders around this to look at the different things that need to be addressed, if you like, to change our landscape around pre-participation screening. Now, that's a kind of 2-year piece of work that lots of partners are involved in, and I living in New Zealand, I'm not actually driving that piece of work. I guess I'm more involved in what sits in the background of it, but it's a really, really exciting time, I think, for this, and probably kind of a world-leading project looking at implementing cross-sector innovation around how we can remove barriers to participation and also improve education and understanding for people. From a moving medicine point of view, we have recently submitted a second consensus paper that's focusing on the public-facing messaging around risk, really, and trying to understand what are the messages and information that members of the public need about this. And also, on the back of that, we've been trying to understand the systems that we can help deliver to support education and screening processes and stuff like that. Well, I say screening process, I don't mean that, I mean, kind of educational opportunities within these contacts. So, I'm not quite sure when this podcast is going to be coming online, but hopefully by that point we'll have our new Moving Medicine Everyone site up and running. And that's really designed to be an online consultation to support members of the public living with long-term conditions make their own decisions about their risk in physical activity. And also to give resources to providers within industry to help signpost and educate members of the public. There's also a really awesome coach bot in there that's a kind of motivation interviewing informed interactive coach bot that will help build people's motivation towards change and also help them understand what kind of and interrogate their own perception of risk. So that's been led by Tim Ansis and Jean Wong. So that's a really exciting part of the website as well. And so yeah, there's kind of lots of things coming, and from an educational point of view to support that, we've developed some educational resources, basically outlining the key evidence and messages that we have around risk. There's a healthcare professional targeted one. There's one targeted for fitness professionals and people working in the sport and leisure industry. And there's also one targeted at people that are doing roles like front of house, where actually that first contact is kind of all important in defining how people feel when they turn up in a space to do some activity. So yes, it's a really, I think, really exciting time, and massive credit to Sport England for their leadership in this. The other key part of this is to basically try and pilot a new system and understand what the feasibility and acceptability of a new system could look like. And we've partnered with Nuffield Health for this, and they, through their charitable arm, they're really doing amazing work in looking at their systems and thinking about how we can kind of challenge, if you like, this paradigm. And a key part of that is the connection to, I guess, that litigation risk. So actually having a big industry provider take on and test out this new system that we're developing together, that's a really important thing. And I think for giving us confidence around how a new system could work and what it could look like, and how that feels for people that are coming into it, if we can make it a really constructive, educational, empowering process, then that would be so much better than a kind of, I guess, a litigious approach where forms that aren't doing their job are kind of providing a barrier to participation.
And just with the chatbot, is that something that you'd be trying to target directly at patients, or would it be kind of more for healthcare professionals to recommend to their patients in terms of where that's going to be marketed?
So that's sitting on the site. That will be it's a public facing site, so people will be able to go onto that site and access the coach bot. It can also be something that healthcare professionals or people in the kind of industry can point members of the public to as well. Yeah, so that's kind of be out there for all on a public facing site.
And then from a healthcare professional point of view, I'm right in thinking there's at least 20 plus condition specific consultations that people can go through for each individual patient's specific condition to help them.
Yeah, so I guess if we're putting the lens a little bit wider, just thinking about physical activity, then we have the movement medicine resources here and a range of consultation guides across numerous medical conditions for adults, children, young people, and they're designed to fit into the space of time available. So there's the kind of 1, 5 and 1 minute conversations that follow a structure that is hopefully helpful for helping empower people to change the behaviour and become more physically active.
Final question: where do you sort of see the future in terms of physical activity in the patients with long-term conditions, and how we get our population more active?
I think specifically in this, and I'll just kind of speak to the risk thing. It's really important that we demedicalise routine activity for people living with long-term conditions. We had a great session yesterday, and Sanjay Sharma, shared his kind of world-leading expertise around screening in athletic populations and elite sport and stuff. And we can be clear that that's a really different population, I think. But for the purposes of looking at regular members of the public doing fairly unremarkable physical activity and avoiding unaccustomed vigorous activity, actually, this should be totally demedicalised. But it should come with a really empowering process to help them proceed with informed consent, because unless they can address and understand their concerns, which are legitimate concerns, and have a place where they can go if they occur, then actually we're not going to change things. So actually it's that opportunity that I think we have going forwards.
Brilliant. Well, Hamish, thank you so much for coming on this podcast. I think the work you're doing in this video is fantastic, and I hope everyone else will agree with that after hearing what you've had to say today. We've got everything, we've milked you for everything you're worth at this conference. You've spoken twice and then come on this as well, so I can't thank you enough for that. And I hope you have a safe journey back to New Zealand.
Hey, thanks, Ed. And I just like to finish by just saying that although I'm sort of here talking, there's so many people that have contributed to this work, and I'd like to recognise Natasha Jones' leadership around this as well. She is a really exceptional driving force behind this agenda. And yeah, just thanks so much for having me here. It's been great to chat.
Brilliant, thank you.